Welcome to the Future of Dermatology podcast. I'm Dr. Farah Kamangar. What you're about to hear is a standout session from this year's SF Derm Conference in Napa, where leading voices in our field gathered to explore what's next for dermatology.
These are truncated replays from our original recorded sessions. Join us in September of 2026 to get the full impact of the SF Derm experience.
We're going to talk about allergic type diseases. And I always think an update on allergic type diseases in older adults has to go with some of the discussion of itching. Itching is our best proxy, I think, in dermatology for the entirety of the aging process. And we're finally getting to a point in how we're understanding itch and age. We're getting to a point where we can actually apply a framework of our knowledge to be able to advance our treatments, our disease schematics, and our approach to these patients. So that's the update here that I'm going to talk about. Try to have this catchy title, something along the lines of how itch tells us the story of our life, our skin, and basically how aging is our proxy with our diseases. Here's my disclosures. Let's first talk about what itch actually looks like when you look at it demographically. Many of you have probably seen this. This is a historical paper, but it absolutely applies today. And the only takeaway here is that itch and age are intimately connected. If nothing else, you've seen it in clinic that itching is an age-associated disease, and that's across genders and across ethnicities. And I always like to point out that it's right about 25, 35 that things start ticking up. So that's probably when some of our innate aging begins. So why is this an important problem? You've seen this in basically every industry now, but essentially our population is aging. And if you look at the data that's current, we're at about 20% of all people in the country are over the age of 65, which is not old, but is basically from an medical standpoint where we delineate the older adult population. So this is growing, and this is actually an international phenomenon. In Japan, you're seeing rates, well over 40%, but this uptick in people over the age of 65 is everywhere. So what about in dermatology? One of the most common things I hear about when I say that I focus on geriatric patients, they say, what's the big deal? I already see geriatric patients. So whether you're a geriatric dermatologist or just a general dermatologist, you're right, either way. Because when you look at it, we see about 40% of all the patients in general dermatology clinics are over the age of 65. And if you eliminate pediatric dermatology, you're getting really close to 50%. So long story short, everybody is a geriatric dermatologist in some sense or another, maybe save the pediatric dermatologists. So let's now look back. We know this is an issue. We know it's a growing issue, but is it a new issue? And spoiler alert, it's not. So if you look back 1,000 years, Paul Avicena was the first one to describe this. And in 600 AD, he said, the itch that comes about with old age cannot be cured, but can be alleviated by a number of procedures, remedies, including phlebotomy, baths, and salves. So, you missed the mark there a little bit. No biologics mentioned. I don't think this is half bad for thousands of years. And I'm going to make the argument that sometimes in our most current resources, we're not quite up to speed. But I think this got a little bit closer when Dr. Robert Willen described this in the 1800s, so hundreds of years ago now. He described it as the first to give a good clinical description of itching in the elderly. The diagnosis of Willen's itch should be reserved for generalized pruritus in the absence of xerosis or other recognizable cause. And this is actually something that Gil Josipovich has tapped in on, that it's not just a population, or itch is not just a disease of either omitted morphology and then internal findings, which I think sometimes our educational systems oversimplify it with. It's actually something that's intrinsic. And a lot of the times you walk in a room with an itchy older adult and they'll have some very subtle skin changes. And you're sort of tasked with this, morphologic challenge to try to characterize it just off really subtle or nondescript skin changes. And in reality, that's really hard for us because that's taking away our superpower, being able to morphologically describe something. But in older adults, we sort of lose that. And I think a lot of times that's what has led us to have lost footing with this population. But in reality, Willen described it as a very real entity. And we should all be comfortable seeing patients who don't have that defined morphology. And that's where we'll get a little bit into later. So this has been around. We know it. It's existed. It's real. Now let's see where our most up-to-date resources, what our most up-to-date resources tell us about it. And of course, you go to ChatGPT, and I asked ChatGPT, what are the causes of chronic itch in older adults? And ChatGPT's answer was very disappointing because I think it completely misses the mark, but I'll share it anyway. Itching, also known as pruritus, can be a common issue among older adults and can be caused by various factors, including dry skin, certain medications, underlying health conditions, or even psychological factors. So I think this is an amalgamation of all the resources, the lay resources out there. And I point this out there not to mock our specialty, but more to show us how much we have to influence some of these systems where people will look for causality. And we have to be able to share what's new in this field to improve this answer, because this is what most patients will come to our office thinking. And if you actually look at most geriatric or aging focused books and you look at their itch, the causality of itch, almost all of them schematically just go right to dry skin, which I think all of us in dermatology have certainly seen itchy adults who have dry skin. But to anchor on that as the sole cause, I think we see, at least I've seen in my career, that's an oversimplification and there's much more to it. So let's get into where we're going with this. So here's the very simple disease schematic of aging skin. And the only reason I want to put this up there is that when you start looking at aging skin, you can see that some of the players of itch are right here. So you have the melanocytes, you have the keratinocytes, you have the senescent cells. As we age, you're seeing more of these changes of these usual players in aging skin that have a role in itching. So you're starting to see the growth of the immune system here, or the change in the immune system here. You're starting to see the implication of keratinocytes, which can have impacts on aging skin and its development of itch. And then the one omitted element here that's really not talked about in the traditional schematic of aging skin is cutaneous nerves, and that's becoming an increasing target. So if we look at this general schematic, you're starting to see that aging skin and itch have a lot of crossover. And one of these fundamental pieces that I think is probably the most important thing you can take away from this lecture is understanding the immune cascade that's involved in aging. And when I was in medical school, I was taught that this concept of an aging immune system called immune senescence was actually a decline of the immune system. And I think there's a subtlety to that I'm going to leave you with. And if you take anything from this lecture, it's that the immune system in decline is not true of just innate aging. What's happening as we're aging is, yes, you're seeing a decline in functionality, but you're seeing an aberrance in response. And I think when I was able to accept that, this was usually I think probably about 5 to 10 years ago, this finally made sense to me, is I started to understand why we were seeing some of this immunologic cascade in our older adult patients, despite the fact that we were all told immunologically that aging meant just a slow decline of the immune system. So when we actually tease apart what's happening to the aging immune system, you see these concepts of immune senescence, which is actually an aberrance of the immune response, not just a decline, but an aberrance. So a decline in functionality, but an aberrance or a chaotic response. And that relates very closely to inflammaging as well, which is a chronic low-grade inflammatory state associated with aging, which includes the process of senescent cells. So let's get into this a little bit. So this concept of inflammaging is this sort of holistic view of what our immune system is doing. And it's contributed to on all these molecular levels. And these are not individualized processes, but things like DNA damage, autophagy, immune senescence, oxidative stress, these are happening in every organ system all over our body. And what we're starting to understand is that as we age, each one of these systems gets off. They go a little bit off the rails. Now they're still functional, but there's a little bit of aberrance to these responses. And this also dives into these feedback loops that we lose with senescent cells. So think about senescent cells as rather really, instead of senescence, I like to call them stubborn cells. So they've basically made their home, they've become fat and happy, and they've just decided to continue their bad habits. And it's not necessarily that they're doing anything wrong, but they're just sitting on the couch having probably a couple too many beers or espresso martinis, and they're just continuing to do that over and over again. So rather than these normal feedback loops, which would clear that behavior, these senescent cells continue. And that's what we're really seeing. So it's not that those couch potatoes are going away, they're just staying put in that stubborn state.
Thanks for joining us today on the Future of Dermatology podcast. If you enjoyed learning about the science behind skin, make sure to subscribe, and we'll see you next time. As a reminder, this podcast is for educational purposes only, not for medical advice. Always consult your healthcare provider.